This is a long case, and
Long
Dr.
case.
Dr. Shiva Prasad will be present here.
Okay, come on, long case.
You can start.
My patient is a 16-year-old student.
Put your collar mic in the collar here. The shirt ka collar. So it is be audible. Come on.
My patient is a 16-year-old college-going student.
Yes.
Came with the complaints of pain in the left hip region
Hmm.
since 4 years, associated with limb. The pain is insidious in onset, progressive in nature, and there is no diurnal variation. It aggravates on climbing stairs.
And silent till the age of 17. This is not correct.
The patient is a.
You restrict to what I told you, what happens, because this is a case which is adolescent. And something could have happened between 8 and 12 or little before.
Yes.
Or now suppose he is not obese and all that. So adolescent Coxsavaira is not there, SCFE.
Yes.
And
the birth history, sir.
You understood or what, students? What I'm asking?
He is a second-born child, born out of non-consanguineous marriage, and had a full-term normal delivery, and there was no perinatal admissions. He was immunized till timely and has achieved the developmental milestones timely. And he practices a mixed type of diet and has no history of smoking or alcohol consumption. And there are no similar complaints in the family.
And college, now 17 is going to college?
Yes, sir, he's going to college. He's done with his 10th and now he's started joining college.
Okay.
So on history, what is your diagnosis?
So what do you feel?
What do you feel? What?
That from the age of 4 years, since 17, that means in 13, he's having this problem. So why should he have these problems in the hip?
So could be late onset Perthes.
From
Okay.
the age of 4 years, he is having. He's telling for
Last 4 years.
4 years. Sorry.
Last 4 years.
Since
So
13, 12.
adolescent onset, that means at the age of say 11?
Is it common in India?
Not that common. But Perthes is common in the southwest coast of India.
So the adolescent Perthes, is it common in India? It is common in India. The late onset Perthes is common in the South India part.
Okay, that is one thing, that adolescent onset Perthes, one thing you can think. What about SCFE? You think so?
He is a tall person, but he's not obese again, and has no other endocrine disorders.
Okay.
Hypothyroidism is not
Right. Then inflammatory. Inflammatory means we have rheumatoid,
Yes.
we have ankylosing spondylitis, and biogenic ruled out, but tuberculosis.
Tuberculosis.
Is it falling into that?
Tuberculosis, there are no constitutional symptoms, no history of pulmonary TB, or any.
JRA, juvenile rheumatoid?
No,
No signs and symptoms in any other joints.
no stiffness and all.
Okay. Then third,
Trauma we have ruled out.
ankylosing.
Ankylosing spondylitis. Age of presentation is not. So-
Normally at the age of 35.
Yes.
Right.
And no one in the family is also having a similar complaint.
So from history and symptomatology, it appears it could be late onset Perthes.
Yes.
That is what I feel. There is no history of steroids. There is no history of
Okay.
smoking, drinking. Is too young for that.
What is COVID to do with it? You told there is no COVID.
So people who are admitted for COVID infections, they usually given steroids that could have caused vascular necrosis of the kidney.
Okay, proceed.
So I'd like to proceed to general physical examination. The body mass index of this patient is 21.4. And on inspection, the attitude is the limb is placed in, the hip is placed in extension, the knee in extension with the neutral rotation of the foot. And on inspection, I've inspected the patient from, clinically examined the patient in sitting, standing, and supine, and from front, back, and sides.
So front.
So on the front side, there is the anterior superior iliac spine, the greater trochanter, the upper polar patella, and the medial malleolus, and the heel seem to be at a higher level on the left side.
Now wait a minute. Now he has got a ASIS which is at a higher level, you're saying.
Yes.
Right?
Yes.
Now keep that in mind.
Ah.
Now you keep
See,
it in mind. Now wait.
Everything has to fall in place.
ASIS at a higher level, you're saying. And
Even
what
if the
else you
examiner
said?
has not listened in the last 5 minutes, he will just keep in his mind what you are told. ASIS is at a higher level. बाकी का आगे चलता रहेगा अभी.
And what you said?
So greater trochanter.
Is at a higher level. Okay. And anything else?
The upper polar patella, and the medial malleolus, and the heel is at a higher level.
So that could be some shortening,
Yes,
right?
there is some
Some shortening will be
in
there.
comparison to the opposite side.
Okay, proceed.
So there's visible wasting in the thigh muscles.
Okay.
There's no scar sinuses or
Huh.
any swelling. There's no
Huh.
fullness of the Scarpa's triangle.
Then, next,
So coming to the lateral aspect.
lateral, yes.
In the lateral aspect, there is no there's no exaggerated lumbar lordosis, and there's no flexion at the hip joint. There's no flexion at the knee joint. The patient stands in an attitude of equinus over the left on the left lower limb, and from the back there's
And prominence of greater trochanter
yes, sir, there's a prominence of
on lateral side.
Yes, sir.
But lordosis is not there.
No, sir.
So the second thing is probably ruled out in my mind. But I'm still keeping ASIS to the higher level. Okay, next.
Then
Posterior.
posteriorly, there's no kyphosis, there's no scoliosis, and the posterior superior spine on the left side is higher on as compared to the opposite side.
There is.
Yes, sir.
Okay.
And there's a gluteal fold asymmetry, but there's no gluteal wasting. The gluteal fold on the left side is on a higher level as compared to the right side.
So the ASIS is at a higher level, the posterior superior iliac spine is at a higher level, but there is no scoliosis. How it is? It is at higher level, no? Higher. So the spine also should be tilted. You're sure? I'm keeping this in mind. What he's saying. Okay?
There's
Okay,
a tilt to
proceed.
the- There's a tilt to the left side.
No. I'm keeping it in mind. Then I will see what is. And if you say some test which I don't know, then I'll keep it more in mind. Proceed. Okay. Palpation. Palpation.
On palpation, so there is no rise of temperature, no difference in temperature. There's anterior joint line tenderness. The lymph nodes are palpable, but the subcentimetric, and they are not significant. There's no fullness in the Scarpa's triangle. There's a smooth rounded contours of the greater trochanter. The femoral pulses are present. There's no thickening of the iliac crest. And
laterally?
So laterally, so there's a greater trochanter prominence with no surface irregularity.
Yeah, okay. Posteriorly, nothing.
Everything is fine.
You don't feel the head out posteriorly.
No,
Okay.
There's no globular mass in the superior lateral aspect.
Okay. Okay.
Posterior side.
Is there transtrochanteric tenderness?
Yes, ma'am. There's a transtrochanteric tenderness. On thumping the trochanter, there's tenderness.
Okay. Then, now movements.
The movements, there's on the left side, hip flexion is about 110 degrees in knee flexion, and it is up to 70 degrees in knee extension. There is 30 degrees of adduction deformity.
Show, because the ASI is at a higher level.
Yes.
Show. Shirt upar karo. Show first of all the ASIS. Take that down.
You like to keep the limbs parallel, even with keeping it parallel to the longitudinal axis of the body.
Yes.
You can appreciate that the ASIS on the left side. The right side is at a lower level, and the left side is at a higher level.
At a higher level. Okay. I can appreciate. Yes. Now you said there is adduction deformity. So
there's an adduction deformity of 30 degrees.
Show.
So to square the pelvis, I will adduct the affected limb. And now I've started. Started to adduct this, and now I have squared the pelvis. Keep the opposite limb symmetrically. I'll also adduct this limb furthermore.
That is for measurement. But what is the adduction deformity? Don't bring that leg in the middle now. That is for measurements.
Yes. This is the adduction deformity. Now I've squared the pelvis with no further adduction possible. Sorry. There's no further adduction possible.
So there's an adduction deformity of 30 degrees.
With no further adduction, and there's no.
So it is fixed?
Yes, sir, it's fixed.
Show me when you try to abduct, what happens? Does the pelvis move?
Yes.
Show. No, from adduction. Now try to abduct and see. Is the pelvis moving?
Hand is moving.
Okay, so the pelvis is moving. Okay, fine. So there's an adduction deformity of 30 degrees, no further adduction, and obviously no
No
abduction.
abduction.
No FFD.
Yes, sir. There's no FFD, but there's no extension also, sir.
Hmm. Okay, rotation.
And rotation, sir, there's a 20 degrees of rotation, internal rotation, and 30 degrees of external rotation with no differential rotations in extension or flexion. So it is the same in extension of the knee and flexion.
Please show.
So Dina chhod dena. I would like to measure the, it is measured with the vertical to the limb. The second, the two limbs of the angle, one of the lengths is the vertical to the ground and the other one is in line with the second toes. This is about 30 degrees of external rotation. Internal rotation. Internal rotation is about 20 degrees.
Show me that ASIS. So that is at a higher level. Okay.
Similarly, in
flexion.
flexing the knee, an internal rotation of about, external rotation of about 30 degrees is possible. And internal rotation is also restricted, which is about 20 degrees. There's no differential rotation. There's no sectoral sign. And there's no axis deviation also.
Okay. Yes. Then
And on coming to measurements,
yes.
there's an apparent shortening on the left side of 5 centimeters with a true shortening of 2 centimeters. And there's an adduction deformity on the left side of 30 degrees. And
Yeah. So apparent shortening of how much?
apparent shortening of 5 centimeters.
5 and true of
True
2.
of 2 centimeters.
Okay. Okay. Yes.
And coming to the girth measurements of the, there's a difference in the girth measurements mid thigh circumference, which suggests that there is wasting about 3
But
centimeters.
shortening, how you measured? By what triangles you have drawn here?
Shortening has been confirmed. The supratrochanteric shortening has been confirmed with the help of Bryant's triangle and Ellerton's line, Shoemaker's
line. Okay. All right. Yes.
Coming to special tests, sir.
Hmm.
The femoral shortening has been confirmed again with the help of Galeazzi test.
Show me Galeazzi.
दोनों पैर मोड़ना.
Not so much. 90.
I can keep the knees 90 degrees. And to look for tibial shortening, look at it tangentially from the front. To look for the femoral shortening, I'll have to come to the side and look at it tangentially, which suggests that there is shortening in the femur.
Femur, correct. Good.
There's no telescopic sign is negative. And Trendelenburg gate is not, Trendelenburg test is not performed in this case because there's a coronal bleeding.
Coronal, correct. Yeah. Correct.
Test for hip stability. Is the hip stable?
Hip is stable?
Yes, so the hip is stable, sir.
Name the test for hip stability.
He can do a straight leg raising test. Sir.
Okay. Then
And in children, we have Barlow and Otla.
in adult, you can do the same thing, not telescoping.
Telescoping test.
Okay, so that is how it is. So what is your diagnosis?
So it is because this mechanical type of pain, as rest pain, and the patient has pain.
Any sacroiliac joint is involved? Have you done any test?
Yes, sir. I was not able to perform the Cancelin test or the test because there's a restriction of movement.
Great.
There's no tenderness at the SI joint. There's no
very good.
spine inward. The ipsilateral, the contralateral hip is normal, and the ipsilateral knee is also normal.
Okay.
So provisionally, my diagnosis is a 29-year-old male, a case of
how old?
How old?
Sorry,
17.
17. Sorry.
Added 29.
17-year-old male. Case of left-sided hip arthritis.
Yes.
Secondary to, I have two differentials.
What?
One is tubercular in origin. Second one is late onset Perthes type of disease. Late onset.
Now tell me, if it's a late onset Perthes disease, do you get adduction deformity? Which is fixed. The hip is subluxated and the hip is moving. As long as it is not inflammatory, like in rheumatoid, like in ankylosing, like in infective or in tuberculosis, there will be no coronal plane deformity. In these cases, there will be arthritis. So there will be either abduction or adduction deformity. So if it is a Perthes, where the Perthes is a case of incongruent congruency, or it is subluxated out. So they retain movements. They have some abduction, they have some adduction. So therefore, the coronal plane deformity will not be there. In this case, the ASI is at a higher level, right? So that means there is some arthritis in that. Okay. So what is your diagnosis? Tuberculosis or Perthes?
Tuberculosis, just because there's no strong evidence.
Hmm.
I am just going by the fact that he has taken
Ah.
anti-tubercular therapy.
Ah,
There's
how
nothing else
many months?
for 1 month. It was started empirical without any,
No, forget it. Ah.
and also that is endemic here. And also because his age group fits in the late Perthes disease.
Hmm.
That is one of the differentials. And another one.
So why should he get a coronal plane deformity of 30 degrees of adduction deformity, which he has? Yeah.
Patient also has a short step non-antalgic gaits.
That is the thing which is coming into my mind. Perthes is one. Second,
Tuberculosis.
but only 1 month's treatment. And if it is 4 years, it can't be this way.
Yes.
There will be some FFD, definitely the restriction of flexion, etc.
SCFE also doesn't
Huh?
SCFE also doesn't present like this. There's a
SCFE, the leg will go outside.
yes.
When you flex, it will go this
Go
way
outside.
because the hip has gone inside.
He has weight loss or is
There are no
anorexia?
constitutional symptoms suggestive of tuberculosis.
Okay, what you want to do?
So I would call for an X-ray.
Show the X-ray.
Oh,
Ah.
interesting.
So X-ray pelvis
Ah.
with both hips, just showing there's a deformed
Head.
head,
Yeah.
and a dysplastic and a deformed acetabulum with increased medial joint space and reduced superior joint space with a broken Shenton's line and incongruous articular surfaces.
Yeah. So your history that patient was totally normal from the age of 8 to 11 is not correct, because such a form of deformity has to occur. That means it is non-congruent. It was subluxating. And you have all those criteria for Perthes disease, those measurements and the lateral pillar and Kate sign and so many things. That will be positive. So in these cases, I would have asked you to take especially focus history on whether he was running, jumping, playing cricket, kabaddi, this, that, with all these kids keep on playing that time. Ask him just now.
बचपन में ज्यादा खेल कूद करते थे क्या?
नहीं, आप सब खेल खेलते थे क्या तुम्हारे पब्लिक के साथ? तुम्हारे कहाँ रहते आप? बिहार में। तो बिहार में बहुत खेलते हैं ना, क्रिकेट, फुटबॉल, कबड्डी, सब कुछ खेलते थे क्या? नहीं, सब कुछ खेलते थे क्या स्कूल में? क्या आपको पैर में दर्द नहीं खेलते थे?
पैर के दर्द की वजह से तू कुछ खेलना कम कर दिया क्या?
पब्लिक
खेल रहा था? कौन से साल तक तुझे अच्छा खेला? 2019 तक।
उसके पहले जो कुछ दूसरे बच्चे खेलते थे, आप खेलते थे क्या?
खेलने के बाद तकलीफ नहीं होता था?
A little unusual, but anyway, this is showing that this has been there for a long time. Anyway,
What
okay.
in the X-ray? Can you describe the X-ray of the acetabulum?
And, there's a deformed acetabulum, dysplastic deformed acetabulum with
What in the X-ray of the acetabulum will indicate to you that the head was fairly congruent up to at least 8 to 10 years of age?
ma'am, the teardrop.
Yeah, the teardrop is very well developed. So that is a good indicator that he had a congruous joint till at least 8 to 10 years of age. After that,
Okay. All right. I think what ma'am is saying is correct. That possibly he had a late onset adolescent Perthes, but yes.
what else on the X-ray? Can you describe both the acetabulum and the head separately?
Ma'am, the head is flattened, it is deformed, it has been laterally extruded with a reduced joint space superiorly and an increased joint space medially. And there's a break in the Shenton's line.
So does this explain the presence of the adduction deformity? does this head explain the presence of the adduction deformity? What is happening?
Ma'am, it is impinging on the lateral aspect of the
Yeah, so what is that called?
hinged approach.
Hinge abduction.
Hinged, but it is so
Yeah.
severe that the leg has actually
Yeah,
gone
so
into
that's how it is.
adduction.
That's what I was thinking, that I am totally surprised as to why he's got that. So because of the hinge abduction, he is not able to abduct. But actually speaking, he may not be having the coronal plane deformity. What ma'am is saying is correct.
Yes, sir.
That is why that surprise thing has to be there in the mind, that why he has got this. In Perthes, it doesn't happen because they have movements, but the hinge abduction is so much that he is not able to have any abduction.
So
You
when-
got the point what it is? Huh? Students, what I'm saying is, you got the point or not? It's a hinge abduction which is preventing abduction. But really speaking, he doesn't have any arthritis of the hip joint, which will give a coronal plane deformity. Interesting case. Difficult.
So a good way to read the X-rays
Hmm.
in the OPD is the mnemonic A, B, C, D.
Hmm.
Okay, A stands for abductor dysfunction.
Hmm.
So now in this patient, does he have abductor dysfunction? So if you see the tip of the trochanter to the center of the head, okay, the articulotrochanteric distance is reduced. The trochanter is high riding, so he will have abductor dysfunction. Okay, B stands for bone. So bony impingement. So does he have any bony impingement on this X-ray? Yes. Okay, he has a hinged abduction. He has got a coxa magna. The head is probably bilobed. Okay, you can see, okay, the enlarged head, bilobed. Probably there'll be a central depression.
See.
C is cartilage. Okay, now there's a lot of hip preservation going on. So in order to differentiate, can this hip be preserved or does it have to be replaced or dealt with otherwise, non-salvage, is to see the cartilage. Now, if you see this X-ray, the joint space is fairly well maintained. Okay, he has a good joint space. He has no pain up to 100 degrees of flexion. Okay, rotations also painless. So C is cartilage. So if the joint space is intact, you would go for hip preservation. Okay, irrespective of what the etiology of the lesion may be. And D is dysplasia. Okay, now dysplasia will lead to instability. So you can have acetabular dysplasia in the form of retroversion. Okay, in this case, he has a slight, have you measured that angle? But, okay, so all the signs, whether he needs a PAO or not. Okay, so D is dysplasia. So you assess the hip X-ray according to these 4 criteria. And each one of these criteria will have a remedy. Okay, so if he has a abductor dysfunction, you can do a neck lengthening, relative neck lengthening. Okay, if he has a bony impingement and he has an FAI, then you have to do a CAM osteoplasty. In this case, you will do an osteochondroplasty. C, cartilage is gone, you have to do an arthrodesis or a hip replacement. And D, dysplasia, you will think of a Dega or some acetabular osteotomy. Okay, depending on the age of the patient.
So what you want to do now?
So,
Abductor to A, according to ma'am, that is out. B, bony, hinge abduction.
osteochondroplasty with
Hmm.
neck lengthening surgeries. And
Neck lengthening.
to accommodate for the abductor dysfunctions.
Okay, all right. Okay, so you'll do a displacement of the greater trochanter
Yes, sir.
Distally?
Distal and lateral.
lateral. Okay, okay. So you you can remove that cartilage and do what you said. Yes, that should be the salvage thing for him.
Shell.
So, no, so in
Shall-
this case,
No.
I feel your answer should be a safe surgical dislocation in order to preserve the blood supply of the head with an osteochondroplasty. Okay, I don't think an acetabular procedure will be required at this stage. Acetabulum is not that bad. You don't need a PAO.
Yeah, so safe surgical dislocation with displacement of the greater trochanter distally and laterally, and removal of that cartilage, hinge abduction. That should be the patient with safe surgical dislocation. So you don't cause more AVN and then hope for the best. Right. Now this X-ray you don't accept in the exam. You have to take an X-ray which is neutral. So you have to go to the radiology department, adduct the limb, square the pelvis and take the measurements. Okay. Okay, chalo.
Sure.
Thank you.
Thank you, sir.
Thank you.
We have